Welcome to the deep dive. Today we're tackling acute cholecystitis, basically, gallbladder inflammation. Our goal isn't just a quick flyby. We're aiming for sort of an audio masterclass here, really digging into this surgical issue from the ground up.
Yeah, it's a really classic presentation, actually. You often see someone come into the emergency room with this sudden, really quite severe pain in their upper right abdomen. It's a great example of needing good clinical pattern recognition. Understanding why it happens helps everything else fall into place.
Okay, let's start there then. The classic patient. We often hear about those F risk factors for gallstones, right? Female, 40, fertile, fatty, fair. Are those still, reliable, or is it a bit simplistic to lean only on those?
Well, they're definitely foundational. They point towards the risk of gallstones, cholelithiasis, and stones are the root cause in like 90% of acute cholecystitis cases. But it's about why those factors matter. High estrogen states, certain lifestyle factors. They promote cholesterol buildup in bile, leading to stones. And we shouldn't forget other causes too, like infections or even hemolytic anemia can play a role in forming different kinds of stones.
Right, so the Fs are mostly about cholesterol stones.
Right.
So if the stones are often already there, why does the acute attack, the ER visit, so often happen right after, say, a big fatty meal? What's the trigger?
Yeah, that's pure physiology kicking in.
Ah.
When you eat fat, your body releases a hormone, CCK, cholecystokinin. And CCK tells the gallbladder, okay, contract, squeeze out some bile to help digest this fat.
Makes sense.
But if there's a stone blocking the exit, the cystic duct, that strong contraction just rams the gallbladder wall against the blockage. And that combination of the physical obstruction plus the chemical irritation from the trapped bile, that's what sparks the inflammation.
Ouch. So that's the sudden pain, the nausea, the fever.
Exactly. It's that inflammatory cascade getting started. The pain is typically right upper quadrant, sometimes radiating to the back or shoulder blade. Nausea, vomiting, fever, all classic signs.
And if that blockage doesn't clear, if it stays obstructed, maybe gets infected, how bad can it get and how fast?
It can progress pretty quickly sometimes. If it stays blocked but doesn't get infected right away, the gallbladder keeps secreting mucus, gets swollen and tense. That's called the mucocele. But if bacteria get in there, which they often do, that trapped bile and mucus becomes pus. And then you're looking at empyema of the gallbladder, basically an abscess inside the gallbladder, which is much more serious.
Okay, that sounds significantly worse. So moving from the patient's story to actually examining them, what are the key things you look for?
Well, you'll definitely find tenderness when you press on that upper right side of the abdomen under the ribs, often some muscle guarding too.
Right.
But the really specific, almost diagnostic sign is Murphy's sign.
Ah, Murphy's sign. How does that work again?
You have the patient breathe in deeply while you press gently but firmly, right under their right costal margin where the gallbladder sits. If it's inflamed, as they breathe in, the gallbladder descends and hits your fingers, causing a sharp intake of breath or a sudden stop in inspiration because of the pain. If that's positive, it's highly suggestive.
Gotcha. So a positive Murphy's is a big clue. Anything else? Maybe jaundice?
You might see mild jaundice, a slight yellowing of the skin or eyes. That usually suggests the inflammation, or maybe a stone is affecting the main bile duct, the common bile duct, causing some backup.
Okay. Now, this kind of severe abdominal pain, it could be other things too, couldn't it? What else needs to be on the differential diagnosis list?
Absolutely. You have to think broadly. Other common things in the abdomen could be acute pancreatitis or a perforated apeptic, ulcer, both emergencies, even appendicitis, though the location is usually different.
Right.
And critically, you have to consider things outside the abdomen that can mimic the pain. A heart attack, an MI, can sometimes present with upper abdominal pain, or even pneumonia in the lower part of the right lung can irritate the diaphragm and cause referred pain there, so you need to rule those out quickly.
Wow, okay. So a careful history and exam are crucial. Then imaging. If you suspect cholecystitis, what's the go-to imaging test?
Ultrasound, definitely ultrasound first. USG of the hepatobiliary system.
Why ultrasound?
It's fast, it's non-invasive, no radiation, and it's really good at looking at the gallbladder. It can show gallstones very clearly, see if the gallbladder wall is thickened, which indicates inflammation, and check if the bile ducts are dilated, suggesting blockage further down.
Okay, ultrasound first. What about a plain old x-ray? Does that ever help?
Less often. Most gallstones, the cholesterol ones, don't show up on x-ray because they're not dense enough. Occasionally, if the stones are calcified or if there are gas fissures inside a stone, you might see this characteristic pattern people call the Mercedes-Benz sign or Siegel sign. But it's rare.
Mercedes-Benz sign, huh?
Yeah, but mostly X-ray isn't the primary tool here. Ultrasound is key. If things are complicated or unclear, especially regarding the ducts, then we might use an MRCP that's like an MRI for the bile ducts or sometimes a CT scan.
Got it. Let's talk labs. If the inflammation is bad, especially if there's blockage involved, what changes do we see in the blood work?
Right, if there's significant biliary obstruction, you'll see certain liver-related markers shoot up. Specifically, conjugated bilirubin and alkaline phosphatase, or ALP, are often markedly elevated. That tells you bile isn't flowing properly out of the liver.
Okay, bilirubin and ALT up. Anything else?
You might see other liver enzymes like SGPT rise too, but one that's really important, especially for planning surgery, is the prothrombin time, or PT. It can be prolonged, meaning the blood takes longer to clot.
Hold on, the PT, the clotting time. How does a blocked bile duct mess with blood clotting? That seems systemic.
It absolutely is, and it's a critical connection. It comes down to vitamin K.
Vitamin K, okay.
Vitamin K is essential for the liver to make several key clotting factors.
Right.
Factors 2, 7, 9X, and X.
Right.
And vitamin K is fat-soluble. For your gut to absorb fat-soluble vitamins, you need bile salts, which come from bile.
Ah, so if the bile duct is blocked.
Exactly. No bile flow into the intestine means poor vitamin K absorption. Your body becomes deficient, the liver can't make enough clotting factors, and boom, your PT goes up.
That's fascinating. A purely mechanical blockage causing a potential bleeding risk.
Precisely. It highlights how interconnected everything is. A surgical problem creating a hematological one.
Okay, that really underscores the severity. Let's circle back to those complications. You mentioned empyema, the pus collection. What are the warning signs for that level of severity?
Clinically, besides the intense pain, you might actually be able to feel the gallbladder as a tender globular mass in that right upper quadrant. And systemically, the big red flag is often a swinging fever. High spikes in temperature, then maybe dropping, then spiking again. That pattern is classic for an abscess somewhere in the body.
Swinging fever, got it. And the absolute worst case scenario?
That would probably be gangrenous cholecystitis. The inflammation is so severe that the gallbladder wall tissue actually starts to die off, becomes necrotic. In those really extreme cases, if you did get an X-ray or CT, you might even see air within the gallbladder wall or inside the gallbladder itself. That's a sign of gas-producing bacteria invading the dying tissue. Very, very serious.
Okay, so the diagnosis is made. Acute cholecystitis, maybe even complicated. What needs to happen immediately before any talk of surgery?
First things first, resuscitation and stabilization, especially if they're septic or very unwell. That means getting IV access right away, giving plenty of IV fluids to rehydrate them, starting broad-spectrum IV antibiotics because infection's almost always involved or a major risk, and of course, good pain control with analgesics, often IV initially, maybe an NG tube to decompress the stomach if they're vomiting a lot.
Right, stabilize the patient. And what about those specific issues we talked about, the clotting problem, potential kidney issues?
Crucial pre-op steps. If the patient is jaundiced and their PT is prolonged, you cannot safely operate immediately. You have to give them vitamin K, usually injections, daily for maybe 5 to 7 days, to give the liver time to catch up on making clotting factors.
Okay, correct the PT first.
Yes, and obstructive jaundice can also strain the kidneys. So you need to ensure they're well hydrated with IV fluids, monitor their urine output, and sometimes even use diuretics like furosemide or mannitol to protect kidney function before surgery.
So managing those systemic effects is vital before definitive treatment.
Absolutely critical for a safe outcome.
Okay, patient is stabilized, PT is corrected, kidneys are okay. What's the definitive fix?
Cholecystectomy. Surgical removal of the gallbladder. That's the cure.
And how is that usually done now? Open surgery.
The standard approach now, the preferred method, is laparoscopic cholecystectomy, keyhole surgery.
Why is lap preferred?
Oh, the advantages are huge. It's much less invasive than a big open incision. So less pain after surgery, much smaller scars, better cosmesis. And the big one is recovery time. Patients usually go home much sooner, often the next day, and get back to normal activities faster compared to open surgery.
That makes sense. But what about those really nasty cases? The empyema, the gangrene, maybe lots of scar tissue from previous inflammation. Can you always do it laparoscopically?
Not always. That's a really important point.
Yeah.
If the inflammation is just too severe, if the tissues are stuck together, if the anatomy is unclear because of swelling or scarring, then trying to do it laparoscopically might be unsafe. The surgeon always has to be ready to convert to an open operation if needed for patient safety. better visualization, more room to work.
Right, safety first.
And sometimes, if the patient's extremely sick, maybe too unstable even for an urgent open surgery, there's another option. We might do a percutaneous cholecystostomy first, basically, putting a drainage tube directly into the gallbladder through the skin using ultrasound or CT guidance to drain the pus and let the acute infection cool down.
Ah, drain it first, then operate later.
Exactly. Drain the infection, get the patient stable, let the inflammation subside a bit, and then plan for the cholecystectomy later when it's safer.
Okay, that covers a lot of ground. We've gone from the risk factors, the Fs, through the block duct and inflammation, the classic Murphy sign, the crucial lab changes like that PT elevation, all the way to stabilizing the patient and the definitive surgical options, usually laparoscopic.
Yeah, I think the key thing to take away is how cholecystitis is such a clear example of a mechanical problem, the stone triggering inflammation and often infection. And recognizing not just the local signs, but those systemic effects like the vitamin K issue is absolutely essential for managing these patients properly and getting them ready for surgery safely. It's all connected.
It really is. So, as you think about this, here's a final thought to chew on until our next deep dive. Consider how that one lab test, the prothrombin time, which reflects a vitamin K absorption issue caused by a simple blocked duct, can completely dictate the timing and safety of major surgery. It forces us to pause and address a fundamental aspect of blood clotting before we can even proceed. That downstream effect of a local problem, definitely something to keep in mind.